needs. So according to the WHO definition, rehabilitation is a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment. So the benefits of rehabilitation are: rehabilitation is an investment both directly and indirectly. Avoid hospitalization costs, reduce length of hospital stay, and reduce readmission rates. And it also enables the individuals to participate in education and gainful employment. They help them to remain independent at home and minimize the need of financial or caregiving long-term physical impairments. Obviously, it's not. And the other one most common misconception is it's an optional service to try only when other interventions to prevent or cure a health condition fail. So there is a global unmet need for rehabilitation, with almost 2.8 billion population all over the world needing rehabilitation. In the rehabilitation, in one end of the spectrum, we have recent advances like spinal cord stimulation, robotic exoskeleton, bladder stimulators, which can be incorporated inside the body. Whereas in the other end of the spectrum, there is a complete lack of care, which leads to complications like bed sore, contractures, urinary tract infections, and the loss of function. So to discuss further, we have two wonderful speakers, Dr. G.Balamurali, who is a head of Spine and Neurosurgery Department, Kaveri Hospital, also the managing director of Hamsa Spine and Rehab Center. He has more than 50 years of surgical training from UK, USA, and Switzerland, and he has numerous awards to his remuneration. Next, we have Dr. Karthikeyan, a consultant in physical medicine and rehabilitation, whose areas of specialization include neuro rehabilitation in spinal cord injury, spasticity management, cardiopulmonary rehabilitation, sports injuries, and gait training with robotic exoskeleton orthosis. So we'll go on to discussion. Welcome, sir. So Dr. Karthikeyan, we have a question for you, sir.
Yes.
So what is rehabilitation and why it is important in our setting, usually in our Indian setup? And what can be done in a rehab center, sir?
Yes. First of all, thanks for a nice introduction, Dr. Kirti. And the answer, the question what you have asked, the answer already you have put it in the previous slides. Actually, the rehabilitation is a concept where it is about the management of the impact of disease on an individual, improve their potential, and thereby improving their quality of life. For example, when we say that a person with a spinal cord injury, fracture vertebra, gets operated, and on the day of discharge, the actual problem of the patient would be difficulty in moving the limbs or difficulty to sit, and they have problems with their bladder and bowel. So really that matters them a lot, and when they go home, it is going to affect the quality of life of the individual as well as for the family members. So taking care of these problems, that is the impact of the disease on a person. We are going to take care of this, improve their potential, and slowly we have to reintegrate them into the society. So as I told in spinal cord injury, it is the same with a person who underwent a cardiac procedure. Then they will ask that whether I can live a normal life hereafter or not, and what are all the activities I can do, I cannot do. So already the disease got treated, but it has made an impact on the individual for the rest of his life, with which he has a lot of questions. So you have to manage them, all these things. You have to reassure him that he can live with a near normal potential. So these are all orthopedic rehabilitation, and then geriatric rehabilitation is coming up very well, especially as you all know, the people with older age, and then they'll have a cardiovascular morbidities. So all these things has to be managed. This is geriatric rehabilitation, and in fact, pediatric rehabilitation is coming up. A lot of children with cerebral palsy, autism, and pervasive developmental disorders. So I would say that the concept of rehabilitation is there it has a touch in all the specialties. Any disease, any problem, once it gets treated, we should make sure that the person is managed holistically and he comes out of the disease, the impact of the disease, and come back to normal life. So this is the objective or the essence on which the specialty of rehabilitation medicine works.
Thank you, sir. So, focused mainly on rehabilitation on a wholesome manner. So I request Dr. Balamurali to explain about Hamsa.
Thank you. Rehabilitation Center is about 2 years old. It is in Royapeta in Chennai. It is a sister concern and an association with Kaveri Hospital. And I'm very proud to say that this is one of the first few centers, or the first center in Chennai, which has a very holistic spine and brain rehabilitation service. We obviously extend the service to other centers, other specialties as well, like orthopedic, pediatric, geriatric, cardiac, and so many other things. We've established this especially um, with the view that we want an holistic care where we have all the specialists like a physiotherapist, occupational therapist, rehab physician, nurses, psychologists, dietitian, and so many other people working together. Now, I just want to give you a very important highlight about why we wanted this center and why only Chennai has one center. Now, the reason is I trained abroad, and when I returned back to India after many years, I realized that as a spine and neurosurgeon, my specialist interest was surgery. So once I operated, I didn't know where to send my patients. The stroke patients, the brain injury patients, the spinal cord injury patients, they all kept going back to their general physician into the community. And there are not many people who understand about rehabilitation, whether it is doctors or whether it is therapists. But there is no center where everybody works together. Yes, the government has a center in Chennai. But not stream, or there's so many difficulties that we are going to probably discuss through this day about why a rehabilitation center is important and what is needed.
So, what are the common problems you treat in the rehab centers, and especially at the Hamsa Rehab Center? What are the common conditions you treat?
Yeah. Majority of any rehabilitation anywhere, the majority of patients are usually going to be people with neurological problems, patients who have limb salvage surgery or major reconstructive surgery. So they're also another big group of people who come. Elderly people in general, because of falls, because of poor mobility, because of lack of care at home, they also need rehabilitation. And then we have the other group of pediatrics, which would be about another 10-20% of our patients. There are some centers in the country and abroad who only do with pediatrics, because they are a huge chunk of patients with cerebral palsy, with delayed milestones, with learning difficulties. So this is another group. The other patients which we are yet to embrace on are things like cardiac rehab. I mean, cardiac rehab is something that is again very much neglected, because you have a huge number of patients who develop MIs, who have post CABG, post stents, valve replacements, And they also need rehabilitation in the acute and chronic phase. So this is something that we are expanding on. We're going to be opening soon. So I think the entire spectrum of all medical problems, pre-operative, post-operative, liver surgeries, major bowel surgeries, they all need a period of rehabilitation, especially in urban population where we do not have sufficient family support for people to take care, and also the lack of specialists who have the experience and expertise in providing the neuro rehabilitation. Centers like this are really essential so that the patients make a remarkable improvement. And in our center, we've treated more than 120 inpatients and more than nearly 2,000 outpatient visits of patients, and that really helps in trying to get them back on their feet. You're muted, Kirti. Yeah.
Sorry. So next we have a question from the audience to Dr. Karthikeyan. So Dr. Balamurali spoke about rehabilitation in orthopedic patients. So the question is, regarding rehabilitation in orthopedics, is it only for pain management or do you have a role in post-operative patients also? If so, what all can be done
So
in orthopedic patients?
In orthopedic patients,
yes.
So in orthopedics, we have two main divisions, like pain management, as it was rightly said, and other one is the post-surgical. In pain management, though the definitive treatment like NSAIDs, pain analgesics are being given, the basic problem will be the altered biomechanics along the musculoskeletal structures. So that has to be properly rehabilitated with well-structured exercise programs, and then so that is the rehab in case of the cold or the pain management goes in this way. And most important is the post-surgical, especially the total knee replacement, total hip replacement, arthroscopic surgeries in knees and shoulders. So all these needs to be properly rehabilitated. When that is not being done, we will not have the exact benefit of the surgery for which we have done. So it is all about improving the range, strengthening the muscles, and improving the bone densities. All these matters a lot to have the exact benefit of the surgery.
Okay. So, okay, sir.
So in case of orthopedics, almost we have a varied conditions. We have referrals from orthopedic surgeons, especially for improving the muscle strength, and then improving the range, stretching and strengthening. So all these are being referred by the orthopedic surgeons. And the most important, as I already mentioned, is the post-surgical rehabilitation. So many times when the rehabilitation is not done post-surgically, then we won't get the exact benefit of the surgery.
Okay, sir. So most of the patients operated, so those who are inpatients need rehabilitation care in the immediate surgical period. Yes, sir. So the next question is to Dr. Balamurali. So how soon the rehabilitation should be started, sir, especially in post-operative patients as well as in a patient recovering from stroke or from any spinal cord injury, who need a rehabilitation? How soon they need, and are there any parameters to decide when to start rehabilitation?
Yeah, I think it's a very, very important question, and probably I would say one among the few important questions that you should understand. There is a common myth among both doctors as well as therapists that after a period of stroke or a spine injury or a brain injury, that we can send the patient home, and then the patient can recover for 2-3 months and then come to rehab. But there's enough evidence, scientific evidence, comparing two groups of patients who had delayed rehab as well as early rehab, and they have unanimously, the evidence clearly says that early rehab, right from the acute phase, has far better reaching outcomes than patients who have rehabilitation delayed. The more you delay, the longer it takes for your rehabilitation and more difficult it is. Very exceptionally, patients who are bedridden for 2-3 years become active. Whereas if that same patient was put through a rehabilitation program straight after an acute care, straight from the acute hospital, they do significantly well, because we not just work on the body, we also work on the mind. Because anybody who, say for example, a 40 or a 50-year-old, we see strokes very early. If you rehabilitate them straight after an acute phase, when they are acutely depressed, and we work on their body, we work on their mind, we allow them to accept that rehabilitation is needed, they do better. The minute they go home, they start looking for solutions. They start looking at, okay, what is the easy option I can get? Is there any more operation? They start wasting a lot of time on doing unnecessary interventions, not understanding the principles of rehab. And then they get very depressed in 6 months, 1 year, and getting them back to a rehab program. And at that time, they've exhausted their finances, and it is very difficult. So my kind request to the audience is, if you feel, if you have a patient with an acute problem, whatever age group they are in, whether they are young or elderly, you should advise and you should push them for rehabilitation very early. So I think that's the answer to your question, that early rehabilitation, whether it is post-trauma, stroke, brain injury, spinal cord injury, immediately after a knee surgery or anything else, starting the rehab from the second day or the first day of the injury or the disease is what leads to better outcomes.
Well said, sir. So here another question from audience. So how to manage Parkinson's rehabilitation? That is, he means what are the rehabilitation available for patients with the Parkinsonism? I think Dr. Karthikeyan will answer this question.
Yes. Actually, the major problems with Parkinson's disease is the slowness of movements, rigidity. So the main problem is the slowness of movement, rigidity, and lack of balance. So these are all the three things that has to be addressed. So whether it may be an inpatient rehabilitation or a home-based program, simple home-based programs are there, where we can concentrate more on these three important problems. That is, to improve their flexibility, to improve their balance and coordination, and there are a few exercises which can improve their tremors as such. So all these exercises as a structured program will improve their activities of daily living. So Parkinson's disease as such, though the problem is there in the brain, the medications, along with the medications, a structured rehab program is very much essential for the best outcomes in a treatment. So we have the exercise programs addressing to the problems of Parkinson's disease, and it is very much essential.
There was a question, Dr. Kirtivasan, from one of the audience about home therapy versus inpatient versus outpatient. So which is the best therapy, and what should be done? So I just like to answer that question. So the way that a rehab program is structured is a clearly evidence-based approach. So there is no haphazard way of fixing an 2 months, 3 months, 6 months. It is all goal-based. It is all based on the patient's requirement. Some patients with mild neurological deficit may only require 1 month of rehab. Somebody with a significant deficit may need 2 to 3 months or longer. So the way that we do it is, in the acute phase, they come from acute hospital to rehab. So they have a period of rehabilitation for anything from 1 to 3 months, an average of about 2 months. And then from inpatient, we slowly shift them to outpatient if they are local. So then they come for, once in a day, once in 2 days, they come for outpatient rehabilitation for some time. And then after that period is over, then we start going for home rehabilitation. So then we visit them once a week at home, and we then continue the rehab. So the rehab extends really from acute phase for anything for up to 6 months to 1 year. So they are under our care, and we holistically manage all their requirements and needs for up to a year. So this is what most rehab centers worldwide in India or abroad would do. So there is nothing that home therapy is superior or outpatient is. It is all depends on the patient. Some patients may only need home therapy. They may only have a minor deficit like a foot drop or a hand weakness or only speech problems. So they don't need to be admitted in a rehab center. So they can have therapy from home. So if somebody can visit them home, there may be some people only may need outpatient. They may live very close within few kilometers of a rehab center where they can come on a daily basis for 4 hours, 5 hours, or a whole day. And then if they have the the facilities at home, they understand, they have the knowledge to look after they need. So not everybody requires an inpatient therapy. So it is really tailor-made to the patient. Yeah.
Whether it is inpatient or outpatient, the rehab should be done. So timely
Exactly.
initiation of rehab, that is more important.
Yeah.
Okay. So we have one interesting question, sir. Actually, thought-provoking question. Many patients feel that after a surgery or procedure, they will be okay. But convincing a patient for a rehab program is difficult. How do we communicate effectively? So how can we communicate effectively with the patient and the caregivers about the importance of rehabilitation? And what are the care provided at a rehabilitation center? Who are all will be available at a rehabilitation center?
So Dr.
Question
Karthikeyan,
to
you can answer that first, and I will also answer my own experience of how to talk to patients.
No.
okay. Dr. Karthikeyan, sir.
I think his camera is a bit stuck. I mean, let me answer that question first.
Yes.
About how do you actually convince a patient for rehabilitation? I think this is the biggest challenge that we face in rehabilitation with in terms of trying to convince the patient, and more than the patient is the family, because some of these patients are in stroke or brain injury, and they are not in a in a situation to understand what is rehabilitation and things. Spinal cord injury patients are probably far easier because they are neurologically the brain function is normal, so they can understand. So there are multiple factors. So if I can break it down into multiple factors, so one of the commonest factors is cost. So cost is one big factor that stops many people from considering rehabilitation, because they have already spent a lot of money in acute care, in ICU, in the wards, in the hospital, and they do not have enough funds to do rehabilitation. And the commonest question asked in rehabilitation is, will I walk? Will I become normal? And you cannot lie. You cannot say that, oh, you're going to walk, you come to our rehabilitation, in 1 month we'll send you walking or running. You cannot say that. It's not going to happen. So then they find that rehabilitation is something that is not necessary. They find that rehabilitation is not going to make a big benefit. The surgery is done, the surgery will make things better and take care. So the way I put it to patients is saying that as much as how acute care or your surgery or your embolization or your stent or your craniotomy or your spine surgery is important, is only 50% of the treatment. The next 50% of the treatment is the muscles that are not functioning, the brain that is not functioning, the bowel problems, the bladder problems, the speech, the swallowing, all these need to be triggered and practiced. And I actually convert that into cost. I tell them that if you don't have a proper rehab, you develop a bed sore at home. You go home, you develop a bed sore. The cost of you healing that bed sore will cost you anything from few thousands to few lakhs. If you develop a urinary infection, your cost of antibiotics, hospital stays, scans is going to cost you anything from 30 to 40,000. And I say that if you have a rehabilitation, this is what it will cost you. It will cost you anything from 50,000 to 1 lakh per month. But if you convert that into productivity, into avoiding complications, you say that you can avoid complications for the rest of your life. So that is how I try to convince patients in the terms of finances. A lot of other things about education. So all they need is constantly educating them, and this has to really come from the doctors. So the doctors who they really trust needs to be needs to tell the patient that rehabilitation is very important. He should endorse saying that only my treatment is only one half, the other treatment is other half. Once the doctor does not say that, then the patients don't understand. It's very difficult for a therapist to convince patients. So I think there are lots of challenges, and I'm just giving you a few examples. So converting them from acute care to rehab is really a key. Dr. Karthikeyan, you can also share your views on the challenges we have in convincing patients and how do you deal with that?
Yes, yes. As you have rightly mentioned, by the time they land up to the rehab center, they would have got physically, mentally, and financially drained. So they'll not be in a position to spend more, or they will not have the people to take care of them. And they feel that the definitive treatment is already over and rehab is just an optional. So still, they do not know what is the impact of the rehab program is going to have in their quality of life. So I feel that it is the responsibility of doctors like us to emphasize on the structured rehab program, which is very much essential for any surgical or conservative management, and when they are suffering with a disease. So I would say that in fact there are changes that is happening among the people. Now they have started realizing the importance of rehabilitation. They have started to think about the quality of life. So it is our responsibility that we have to keep emphasizing. And there are other many social factors, like they are not able to, even there will be one family member who was all these days on leave taking care of the patient, and they say that they cannot spend more leave on they cannot take further leave. So these are all the financial and social factors that is really having an influence on the rehabilitation. So it is in an optimistic way, I would say that things are changing, and we should keep reinforcing that what is the importance of rehabilitation.
Okay, sir. So about the cost factor, there is a lot of queries whether the rehabilitation care can be covered under insurance. What's the take on insurance about rehabilitation?
Yeah. So, I mean, at the moment, in India, rehabilitation is not covered under insurance. But I can assure you that in the very soon, in the next 2 years, most insurance companies are looking towards giving payouts for rehabilitation, especially for stroke, for spinal cord injury, brain injury, certain neurological disorders, and post-operative. So I can assure you that I'm involved in with some of the companies in developing policies, and it will come out soon. So right now, you can only claim for physiotherapy, you can claim for speech therapy, and certain things as an outpatient for a certain period of time. But beyond that, it is not covered. So it varies from insurance to insurance. So you can check with the patient with their insurance company. But as of now, insurance is not covered. And I think this is the biggest challenge that India is facing in terms of the middle income and the upper middle income people who have to pay out from their pocket for acute care. And when it comes to rehab, we have challenges. I think there are a few questions. If you can also go through those questions, Dr. Kirti.
Yeah, yes, sir.
Hello,
So
am I audible?
Yeah, you're audible, sir. Well, we
I
cannot
lost
see your video.
So we cannot see your face. I think his video is a little stuck, but we'll proceed.
Yeah, yeah, sir.
Yes.
So another question, sir. So I'm just rephrasing the question. So in your experience, how's the life of the patients after rehabilitation, sir? Especially the elderly patients after stroke? How's their life compared to the patients who has not taken rehabilitation care?
Kirti, I would say the list of problems that happens after a stroke. The patient starting from higher centers, aphasia, lack of this cognitive problems, and there will be a tightness, spasticity of upper limbs and lower limbs. Somebody may have neurogenic bladder and bowel. So definitely a person cannot live with all this problem normally. And if we don't intervene these problems, obviously they will develop with a lot of spasticity, contractures of joints, and then over a period of time they'll not be able to get up from the bed due to musculoskeletal complications. And obviously they will develop bed sores of various grades, and then the neurogenic bladder will give rise to the urinary tract infections, bladder stones, hydronephrosis, contracted bladder. So these are all a big spectrum of problems. That is the sequelae. If we don't intervene the stroke, post-stroke period, this is the sequelae that is going to faced by the patient, and obviously this is going to affect the quality of life or the, in fact, the longevity of the patient. So obviously, beyond any doubt, even with our naked eyes, we can see that the rehab is very much essential when all these problems are going to happen in a patient. So the structured rehab program in a stroke patient or a traumatic brain injury is, obviously, it is a teamwork. I have seen in the community that many times the patients are being dealt with or treated with physiotherapists, and the musculoskeletal problem alone being is taken care of. So I'm mentioning this with due respect for all my physiotherapy friends. But the problem is not only the musculoskeletal in stroke. There is psychological issues are there, communication problems are there, and we have bladder bowel problems, balance coordination. So all this requires actually a team of rehab professionals like speech therapists, physiotherapists, occupational therapists, and we have we need a team of medical professionals like rehab physicians, spine and neurosurgeons, urologists, plastic surgeons. So the rehabilitation is a teamwork which involves a set of medical as well as the paramedical professionals. So in that way, I would say that rehabilitation is very much essential. So obviously, the person, when we compare a person who don't underwent a rehab program and who has gone, who has undergone a rehab program. So when you see a person who has never gone to a rehab center, he will be lying on the bed with a lot of contractures, with tightness of muscles, with a lot of with the suprapubic catheter or indwelling Foley's catheter there on the bed. A person who has gone and attended a rehab center will be walking with or without support, with not much of any of these complications. So this is the comparison which I want to highlight.
Okay, sir.
No, I think I just wanted to add an emphasis to one point that he was trying to make is the huge difference between doing home therapy or giving therapy at home compared to a rehabilitation center was very nicely summarized by Dr. Karthikeyan. So as I said, a lot of people, the general public and the doctors feel that, okay, we can send the patient home, we can send a physiotherapist, we can send a speech therapist, we can send a psychologist, we can send everybody home. Yes, it's possible. Yeah, but the communication, it's a teamwork. Like, if I want to do an operation, I cannot just go and do, say, okay, I'll put the patient to sleep, I will scrub up, I will also assist, I will also do the operation. It's not possible. So my operation theater has a huge team of anesthetists, anesthetic assistants, my scrub nurse, my assistant, the person who brings in the blood to the theater, my instruments, my equipments, sterilization. It's a huge teamwork for the success of whether it's a 10-minute operation or a 10-hour operation. The same way, if you take the patient holistically, especially stroke patients, I think the stroke patients are probably the most difficult patients to rehabilitate because they have a huge spectrum of problems. They have bladder bowel issues, memory issues, cognitive issues, stroke, swallowing issues, speech, aphasia, and everything needs to be addressed by a different person. So you need a speech therapist, you need a dietitian to control their diet, you need a psychologist to talk to them about their mental problems, their cognition, and you need doctors, all the doctors that Dr. Karthikeyan listed, physiotherapists, occupational therapists, hand function, activity of daily living. So this cannot be coordinated in a home, at home. Not everybody is going to sit down and talk together. Not everybody is going to update and communicate. So in a rehab center, we focus on getting everybody together. Everybody discusses, we do a ward rounds, we see the patient, we discuss about the patient, and then that is how the patient benefits immensely from a care of so many people around them and so many specialists putting their thoughts together for the benefit of the patient.
So it's well known that chronic condition, especially stroke or spinal cord injury, any chronic condition is associated with a psychosocial impact, especially depression in the patients, and also among the caregivers. And also, we have a question from the audience: how to address these psychological issues during the rehab? And what is the role played by the psychologist here?
Yeah, Kirti, actually, a timely start of rehab and maximum help or assistance from the rehab team would normally lessen the caregiver's burden. The caregiver's burden, when it becomes more, is when the caregiver's burden is proportional to the problems of the person involved. That's it. So the patient. So as long as when we keep the patient's or person's problems and the complications minimal, that is the first strategy to address to the caregiver's fatigue or caregiver's depression or any psychological impact. So timely rehab is very much essential, right? Of course, after coming to the rehab center, when we feel that the caregiver's fatigue is there, we have a program that we very frequently interact with the caregivers, assess their mental status, assess their interest and involvement in the rehab program, because the caregiver's interest and involvement is very much essential, and which is the one which completes the success of the rehab program. Unless the family member is not involved properly, then whatever the efforts we put, it is not going to give the desired results. So equally, the caregiver's wellness is much important. So very frequently we interact with the caregivers, and we have psychologists with us. We make them to interact with them, and at the same time we see that we make sure that what is the reason for the caregiver's fatigue. They say that every day I'm not able to sleep, sir. Throughout the night he is not sleeping, cough is there, and there is a problem with the tracheostomy, and he pulls out the Ryle's tube. So we address the problems that is there with the patient, that is really causing the fatigue for the caregiver. So it is all about we cannot make the as the two discrete entities, the patient's problems and the caregiver's fatigue. So we see as one as such, and we parallelly treat the caregiver's fatigue and the problems which is causing the fatigue for the caregiver. So this is how we follow the policy, and I would say that addressing to the caregiver's wellness, that is equally important, and we give due importance for this in our Hamsa spine and brain rehab.
Okay. So, Balamurali sir, can you please elaborate more on the role of psychologists and the psychological impact on the patients?
So
We heard yes, sir. Yes, sir.
yeah.
Please proceed.
So if you just imagine, you have a young person who's in his 25, 30, coming up in his career, ambitious, young family, just married, kid, and suddenly he has a spinal cord injury, and he's told that you're not going to walk for the rest of your life. Imagine what would be the state of the mind of that person. So, he's not going to want anything after that. He's only going to want solutions to walk. He's not going to cooperate for rehab or anything. And his only thoughts are about how is his life going to be for the rest of his living. So, they are really very broken mentally, as much as they are physically. So, this has to be addressed in a very, very early stage. Very few people can self-motivate and come out of their problem by themselves. 95% to 98% of them need help. So there, the work and the importance of a psychologist is there, by trying to talk to them, trying to motivate them, trying to give them all that is required to bring them out of that acute phase, without lying to them and saying that, giving them false promises, but still giving them a hope after life, because it's only the legs that has gone. They still have a good mind to work. Probably based on what their job is, they can get back to some work in their life. So I think the importance of the psychologist is very much underestimated in rehabilitation in many places. And I think they have a very, very vital role in trying to bring the patient, one, to accept rehabilitation, to accept their problem, to accept their disability, and then getting them out of that in many ways. So I think it's very, very important.
Yes. So we have some questions about pediatric rehabilitation. I think Dr. Karthikeyan can answer these questions.
Yes.
So what is the role of rehabilitation in Erb's palsy apart from a positioning of the patient? Rehab management in children born with Erb's palsy.
Erb's palsy.
Yes, Erb's palsy.
Right.
Except the positioning. Other than positioning, what else can be done?
That is more important. The positioning of the child is very important. Usually, we don't even involve the therapist. Even before the therapist, we involve the grandmother of the child. So the positioning and passive mobilization of the limb is very important. And that is the only thing. So as the child grows, when the muscle gets strengthened, so the positioning and the passive mobilization and the prevention of tightness, that is the first thing that is more important. So apart from that, during that age, we can't do anything unless and until they land up with any complications. With the proper positioning and passive mobilization, that suffice. That itself is enough.
Yes. Sir, I think they want to know whether electrical stimulation, those kind of things have any role in electrical stimulation.
No, actually, yes. See, one thing we should make sure that the electrical stimulation, the muscle that is present in Erb's palsy is initially it is denervated, right? So in that case, when we keep stimulating the denervated muscle, it is just like whipping a weak horse, right? So it can cause over a period of time, it can cause muscle soreness, and the child will be reluctant to move. So the role of electrical stimulation in Erb's palsy, in fact, I feel that there is no concrete evidences. So it is a growing muscle, it is a regenerating nerve or the nerve roots. So we should keep on positioning and keep moving by passive mobilization, allow the natural process to recover. If that is not happening, then we have to evaluate by various investigations, and if needed, we can take the help of a neurosurgeon or a spine surgeon. But Erb's palsy, as such, first line management is positioning and passive movements. So that is there. The electrical stimulation, as such, don't have the role in the front end.
Thank you, sir. So next question to Dr. Balamurali. So we all know that Dr. Balamurali is running Hamsa Rehab Center successfully for the past 2 years. We want to know what are the challenges you face in running a rehabilitation center, sir?
I think we need a
It's been,
separate.
yeah,
I think we need a separate webinar to discuss about the challenges that we have. But I'll just highlight a few things which is relevant to the audience. One is, it's like running a hospital. When in a hospital, you have many specialties, doctors from various subspecialties and the services put together where you all, work towards the patient. Very similarly, we look at many departments and many subgroups of people within the therapy. Physiotherapists, occupational therapists, speech therapists, nurses, doctors, and the administrative staff. So getting the team dynamics, getting the team to work together. There is always conflicts, there's always debates. Some are good and healthy, some are not. So all that needs to be managed. I think that would be the biggest challenge in a rehab center. And I think, we have an excellent, vibrant young team of therapists and all, under the leadership with Dr. Karthikeyan. We're really able to bring this together because, it's collective knowledge is better than individual knowledge. So the collective knowledge of all the therapists in terms of how to make the patient, who is the center point of the therapy, to have a good outcome and go home better. So that is the challenge number one. The second challenge is the attenders, the relatives of patients. So the patients' relatives in the urban society, the challenge that we see is most people think they just can come for 1 month, they can see some results, take the patient home. They're not very realistic. They have money, some of them have a lot of money, some of them have no money. So the challenges are different with different groups. But the most important thing is to convince, even sometimes when the patients want to stay long, the relatives have said, well, we don't have time, they don't have the patience. they don't have the money, and they have to go for a job, the children or the husband or the wife, and there's nobody to look after them. So that is another big challenge. The next one is, if you look at the therapist itself, not many therapists have the experience of having worked in a rehabilitation center. When I interview people for physiotherapy or occupational, whatever jobs, very few of them have actually worked in a rehabilitation setup. So in training the team is a very key aspect of our at Hamsa, where we actually have regular training programs, teaching programs. In fact, even we are starting a rehabilitation course, to so that we need to have more and more people understand about rehabilitation. The patient factors are actually not much. The patients are actually more cooperative. Yes, sometimes patients want to go away quickly, and that has to be really a lot of psychological. And it is a lot. The environment in which we have to provide rehab also should be a very nice environment, and a fertile environment where there is good healing, there is quietness, there's calmness, there's a very systematic rehabilitation. The patients, the attenders, the team, they all work together. So they all have to understand why the patient is there, what is happening this week, what's going to happen next. So the education, the communication. So I think these are the biggest challenges that I face. I think the center, the finances, the business is not a challenge. It is a challenge of actually getting the team together to work harmoniously in a very nice environment. And I think that is where we've been very successful in trying to get our team to work, and our patients are very happy.
So continuation of your answers, right? So we are very sure that you know all these challenges before starting the rehabilitation center. So what made you to start this rehab center at first?
Yeah. So as I started off saying in the beginning, most of the challenges that surgeons have is, you do an excellent operation, you put a lot of effort to save somebody's life, and then what? Where do they go? You cannot keep every patient in an acute hospital. Whichever hospital it is, the cost of healthcare is very high, and it is only rising. And also there is no need for a patient who has a disability or a stroke, or only has a speech problem, or only has a bowel bladder problem, to stay in an acute hospital for as long as possible. Insurance also runs out after some time. Insurance companies also cannot compensate for a very long period with the expenses. So there needs to be an intermediate care. And that is when I trained in UK and US for more than 15-16 years, and when I came back, there was no intermediate care available. There's either acute care or you have smaller polyclinics. So there is no place where there's an intermediate care, and that is why I did my homework. I did a lot of research in the country, and then we started the Hamsa Rehab. We have learned a lot. We have we've had challenges from various sides, from patient factors, challenges of the business, the challenges of the team, and training the team. But I think we've kind of cracked that model, and now we are very confident, and that's why we are expanding. Because I think this is very important, because the future is going to be more about chronic management, chronic healthcare management, managing elderly people. After especially the COVID, most patients don't want to come to hospital. They want to have a smaller intermediate setup. They're afraid of acute care hospitals. And I think, for the next few years to come, for the next, I would say next 2 to 5 years, we're going to have challenge in patients wanting to come to hospital for treatment. So I think that these were the challenges I knew, but we've been able to do it.
Yes, Kirti, I want to add up.
Yes, please.
In fact, the same question I had, what you said, how a spine surgeon is starting a rehab center after knowing all these difficulties. This is the thing which I had in my mind, which you have rightly put as a question in this forum. So even I used to think, why a spine surgeon who can make huge money out of surgeries, and why he has started a rehab center. Of course, he is doing very well. I admire his passion. Usually, it's very unlikely to have a surgeon getting involved in the process of rehabilitation. In fact, for this reason, I admire Dr. Bala. And after knowing all these difficulties, he has started a rehab and running a rehab. Just I would like to quote an analogy that it is just like a female willingly getting pregnant after knowing the labor pain, after knowing about the labor pain. So in that way, I very personally and closely watching what are all the difficulties he is facing, and very with a very good talent and with lot of involvement, he is managing all that. And I'm sure that the Hamsa will become a standalone center which can offer the excellent rehab care in forthcoming days.
Okay, sir.
Thank
So
you for your kind words.
So we have some more questions regarding rehabilitation. So it's about a particular condition. So how will you rehabilitate children with attention deficit hyperkinetic disorder, ADHD?
ADHD.
No
The
one
question.
question. Yeah. Yes.
Yes. The question is very, to answer this question, it requires a lot of, it is not so easy to say that how will you rehabilitate a child with ADHD, because the rehabilitation of ADHD, the results are itself is very controversial. We do not know how far the child will respond. It depends on the trait of the child, their family environment, and all those things. So basically, the primary problems are the poor attention span, lack of concentration, and the impulsiveness. So these are all the problems in a child with ADHD. So I have come across few children with ADHD, and I would say that there are many factors which are really contributing for the child's behavior. It will be from the parents, right? So it is all about a comprehensive interview should be done with the child among the family members, or who are the members who are present in the family, and accordingly, based on the symptoms or the child's behavior, we have to make uh, a customized program, rehab program. And I would say that we should be very friendly, and we should be flexible, especially in treating children with developmental disorders like ADHD. So, and when we force something, it is not going to work. Many times they have goals, rigid goals, and rigid ways of implementation, like how the child should be, these and that. I have seen it has never worked. So it is all about. It is very difficult to make the time limits how the child will react to your rehab program. So my important point is, you make sure that the factors are not only with the child, it may be with the other family members. Many times the primary reason for the abnormal behavior of the child would be the family members. They will not react to the child appropriately. So it's equally important to counsel the family members and the child. And we have to make a very detailed interview of all the issues that is there with the child, and accordingly we have to customize the rehab program. So that is what I would say. But I am sure that I have not answered straightforward how will you rehabilitate. In fact, even I don't have a single sentence or a straightforward answer for this. So it is all depend upon the situation and the child.
Yes, sir. Sure, we understand that it's a complex situation. Next, a
Yes.
question to Dr. Balamurali. What are the recent advances in rehabilitation, sir?
Yeah. So I think the rehabilitation is, as I said, one area of medicine that is very fast growing, because the entire world we have an aging population, the longevity of patients are much more. We have better technology in terms of dealing with neuro problems, spine problems, orthopedic problems, trauma. So we are able to save and help many people in the acute phase. Now, the problem is the more technology that goes in acute phase, it has to be reflected in the chronic phase as well. So we need the same technology to look after and benefit people with disabilities. So if you see the research, there's already a lot of research questions here in this group, and I'm sure there are a lot of students and people in PhD programs who are doing research on so many things in terms of robotics, electronics, in terms of rehabilitation, technology, games, and so many other things are all coming up. And so the advances have not reached India yet. A lot of them. They're probably in most of the Western countries, like robotics for walking. You have various, gait trainers. You have balance machines. You have assessment of the gait, assessment of balance. So there's so many things for coordination of hand-eye movement, for coordination of body movement, for an post amputee. How do you train them? So for pediatrics, how do you train them with games? So you need to evolve. We are evolving a lot. So I think all these are coming to India soon. More and more hospitals in Delhi, in Mumbai, in Bangalore, they are embracing all of these things. And I think it is not before a lot. We are going to embrace them in Hamsa as well, and we are going to get a lot of equipments in Chennai too. So there is a huge shift in how we are looking at rehabilitation, and people are not only looking at rehabilitation for illness but also for wellness. For example, if you want to go on a hike, if you want to go on an adventure, you need to improve your endurance. And so there is a lot of rehabilitation now in the cardiac area where people want to improve their endurance. Are they going to test their endurance at high altitudes? How do you do that? So there's going to be a lot of changes there. Next is in sports medicine. So in sports medicine, again, there is a lot of rehab because more and more people want to become professionals in sports. And how do they become very good at it? How do they train? How do they improve their muscle mass? How do they prevent injuries from happening? How do they deal with injuries? So this sports medicine again is something that's going to come up. Hydrotherapy. There's so much now talk about hydrotherapy and how the equipments are going. We have so many Bluetooth enabled devices, whether it is to test EMGs or EEGs, looking at the performance before and after trauma, looking at performance before and after injury. So the technology is really vast and far moving. Yes, the problem with technologies is expensive. These probably cannot be affordable to everybody, but still we are going to get that. And still technology is going to help in movement. But I think the first point is we need to first encourage rehab. Technology only comes next. Even without technology, we are able to give excellent results. With technology, probably we may be able to give better results for those who can afford it. And if insurance comes, then advances will become more. In terms of medication as well, medicine, so we can do more Botox injections, spinal cord stimulators, baclofen pumps. We can do so many operations now where we can transfer tendons. We have a brain spine interface research going on where if you have a spinal cord injury, you can actually have a connection from the brain directly into your spine. And there are so many other stimulators and other things that are coming up. So I think in the next 10 years we're going to see a huge boom in how rehabilitation medicine advances in terms of technology and advancements. So I think this is the right time for people who are therapists who want to take over rehabilitation as a primary focus, because more and more hospitals, more and more healthcare is going to come in this area.
So about recent advances, we have one question, rather research question from one of our audience, Dr. Karthikeyan sir.
Yes, please.
Yes, sir. So can you please explain about the role of video game based exercises, that is VR based exercises in stroke rehabilitation? Can they help both mentally and physically?
VR based exercises, yes, definitely they have a role. There are evidences that VR based or video game based or virtual reality based interventions that really have an impact on the prognosis of the stroke patients. At the same time, I have seen a few Cochrane evidences that still it is not yet proved. So it's a few meta-analysis when we come across in the Cochrane database, they say that it is not all aspects of stroke rehabilitation the VR takes care of, right? So, but in that case, I would say that definitely it has. Even in my personal experience, virtual reality really helps the patient's progress in stroke, especially in terms, especially for upper limb functions, hand functions, balance and coordination. So these are all the areas, problems associated with stroke. The virtual reality really helps. Yes, I would say positive reply for virtual reality in stroke.
Okay. So we have two more specific questions, sir. So what are the rehabilitation management available in Hamsa for a patient post amputation, both upper limb and lower limb?
Post amputee.
Amputee, yes, sir.
Okay. Okay. So post amputee, it is any post amputee, that is the standard protocol that is being followed in Hamsa. That is first and foremost is the proper rehabilitation in the amputee starts with the level of amputation and the length of the stump. So that it depends on the decision making of the orthopedic surgeon. So the proper amputee rehabilitation starts with the involvement of the orthopedic surgeon, right? So immediately we can classify as immediate post-operative and then late. Then during the immediate post-operative period, the stump care is very, very important. A good stump is very much essential for proper prosthetic fitting. So stump edema has to be managed with compression bandage, and the muscle tightness or the contractures has to be prevented by proper positioning, passive movements. If possible, the patient has to be put in prone position to prevent hip flexors contracture. So proper positioning and passive mobilization, compression bandage of the stump are the first and foremost essential things, which has to be started during the immediate post-operative period, right? And subsequently, we should make sure that the stump has regressed, all the edema has regressed to completely, so that when we measure for the socket, right? When we measure for the socket, if there is an edema, then what happens is when the socket comes for fitting, by the time the edema regresses and the socket becomes loose. So make sure that the socket, the stump edema has regressed, and there should not be tightness of the hip flexors and knee flexors. So make sure that there is no tightness and adequate strength is being maintained in the muscles around the joint involved. So no tightness, adequate strength. So this is the most important, and make sure that the stump is primed well for socket fitting. So once the socket is fit, that is, we have a structured rehab program with the prosthetic fitting. So as you all know, within the parallel bars, and then with the bilateral support, unilateral support, and then with walker, likewise step by step we can improve improve in the gait training. And one first and foremost thing which I want to highlight here is, when we concentrate on the lower limbs, many times we don't give importance to the upper limb strengthening and the endurance training. By the time when all these days the patient was walking normally, now he has lost his limb. The gait training or the walking with a unilateral limb support or with an orthotic support is going to be more laborious, right? Especially when the patient, when we want to train with auxiliary crutches, it is not like normal walking, it is going to be laborious. So in that case, we have to train the upper limbs, especially the crutch muscles, because immediately after the amputation, when we want to initiate the auxiliary crutch walking, the patient will say that my shoulders are paining. Now the problem from the knee or the amputee side, the problem will get shifted to the shoulders. So when we have a plan of gait training to have auxiliary crutches at one point of time, from day one, start strengthening the shoulders, because all these days he never thought of auxiliary crutch walking. Now we are going to introduce that. So from day one, you start strengthening the upper limbs, especially the crutch muscles, so that over a period of time we are going to use auxiliary crutches, right? And second thing is, as I told you, the crutch walking or walking with the socket is more laborious than the normal walking. So all these guys will have a poor endurance. and only when we attempt to walk, then he will say that I'm not able to walk, sir. Muchu vaangudu. I cannot walk. So after that, we cannot spend more time on training for his endurance. So along with the stump management or the limb, managing the limb involved during the amputation, from day one, start strengthening the upper limbs, start endurance training, because that is going to be very much useful for further rehabilitation with prosthetic fitting. So this is the one point which I want to highlight.
Thank you, sir. So we are running short of time. We will last question, sir, one quick question. So on which stage of spasticity do you prefer Botox injection? Do you prefer Botox injection regularly in patients?
Yes. So Botox in spasticity, we have certain important points that has to be considered. We have, as you all know, as per the modified Ashworth scale, we have 4 grades of spasticity, right? So usually first and the second grade, we don't contemplate for Botox. Third and fourth, we can take it up. And before that, a chronic or a long-standing spasticity, which has made the joint to be in the deformed state, would have caused the contractures or the capsular contraction of the joint, right? So we should make sure that the problem, the spasticity lies only at the level of the muscle, and it has not caused any contractures or the capsular contraction along the joint, because already if the muscle is on contracture or the muscle has shortened, when you give a Botox, it is not going to work. It is because already it has gone for contraction. So stage 3 and 4 we can select, right? And before that, before injecting the Botox, make sure that the muscle has not already gone for contracture or the joint has not already gone for deformity, because it is not going to give the desired result. Okay. And another important thing is, in my personal experience, the Botox in lower limbs is not so promising. Why? Because the maximum dose of Botox in an individual will be around 500 to 600 units. 500 to 600 units. When we calculate the dose of Botox based on the muscle mass, for example, if a person is having hip flexor contraction, hip flexors, adductors, knee flexors, ankle flexor, plantar flexors, when we calculate, it will exceed the maximum permissible dose of more than 600 units. So, wantedly, we have to undertreat the spasticity of lower limbs, taking into account the safety level of the Botox, right? So, in that case, the spasticity management, extensive, involvement of many muscles along the lower limbs, I have not seen much promising results. But upper limbs, stroke in upper limbs, especially the shoulder adductors, elbow flexors and pronators, all these things, because the upper limb muscles will need a lesser dose, where we can give the complete desired dose so that you will get the results what we want. So these are all the things which I want to highlight. Grade 3 and 4 modified Ashworth scale, no contractures or shortening of the muscles, no deformity of the joint, and make sure select the muscles which really need Botox, because it requires a careful planning of what are all the muscles that has to be given. For example, if it is gastrosoleus, make sure that what actually is causing, whether it is a gastrocnemius or a soleus. So we have to be very judicious in injecting the Botox, especially in lower limbs. I think I have answered.
Yes. Thank you, sir. Very interesting answer. So we have almost come to the end of our session, sir, with rather an interesting session. So Dr. Balamurali, do you want to add anything, sir, as a concluding note?
Yes, I think first of all, thanks to all the audience for, on an auspicious day, happy Ugadi to all those of you who are celebrating to be here with us. The whole point of this webinar was to highlight the importance of why rehabilitation is so very important and so very essential for the patient in the long term. Because I feel the most important thing out of, apart from the patient benefiting from the rehab, the patients, it's a lifelong learning about how to avoid complications. Because most of them are going to live with this disability, whether it's a brain injury, spine injury, stroke, or something. Most of them are going to live with this for the rest of their life. It's not that their disability, because they come to a rehab, is going to be reversed. But they learn how to avoid UTI, how to avoid a bed sore, how to avoid contractures, how frequently they need to check up. Because every disabled person from whatever age, they're still going to get old as well. They're also going to get medical problems, diabetes, hypertension, osteoporosis. But how can a person on a wheelchair manage that? So this is something that people, the public, need to understand. But first and foremost, doctors and therapists need to understand the importance of teamwork, the importance of a rehab center. And that is the reason why we thought that we will have this webinar, so that we are able to share our knowledge about the challenges, difficulties, and the importance of rehab, because we see results. We see people who have been chronically bedridden and come for rehab, and how we find it difficult to get them back, to patients who come from our acute care directly to our rehab center, where they show a significant improvement and they go home happy. Thank you all so much. And I think we will have more questions answered. You can write to us, you can email us, you can visit our website at Kaveri Hospital or hamsarehab.com, and you can post the questions to any of the three of us. We all three of us work within the rehab setup. Thank you all so much.
Thank you. Thank you so much.
Thank you, doctors. Thank you.
Thank you, sir.
Thank you.
So I want to thank all our audiences for their very interesting questions and making this session very informative and interesting as well. Thank you all.
Thank you, and thank all those who have been working behind to set up this meeting. Thank you, Srivatsan, and thank you from the IT team from Kaveri Hospital and Hamsa. Thank you.
That's it.
Yes, yes.
Good day.
Thank you.
Bye.
Thank you, sir.